Manish, thank you so much for that wonderful presentation. Having someone that was involved with the steering committee and with the trial gives you the added benefit. Let me go to the meat of the matter, in my opinion. There's a lot of concern about the clopidogrel situation. Many of us are very comfortable with dual antiplatelet therapy after endovascular intervention. Here we're comparing rivaroxaban plus aspirin versus aspirin alone. And many of my colleagues are a little bit concerned about this. Can you tell us what the data shows, the subgroup analysis and other things related to that?
Yeah, thanks, Mehdi. The first thing I'll just say is that my thinking about antiplatelet therapy and PADs changed over the last 10 years. I was involved also in Euclid, where we took ticagrelor versus clopidogrel. And if you said to me, who's going to benefit before, obviously we were fooled. We thought ticagrelor, a stronger antiplatelet in the coronary, would be better in the periphery. And we didn't show that. And I remind us in the talk that charisma, at least broadly, didn't show us that dual antiplatelet wasn't better than monotherapy with aspirin in broad vascular patients. So we too were interested in this question, but we didn't, it's important to recognize randomized clopidogrel and Voyager. We allowed the use of it. So people got rivaroxaban aspirin or aspirin alone, and then they could have, after the intervention, clopidogrel. Most of those patients were endovascular, but there were some surgical. And I think the presentation Will Hyatt did at ACC, hopefully will be out in press soon, showed a few important points. First is that clopidogrel use occurred for about 30 days, and about 50% of the patients got it, most endovascular. Clopidogrel use was associated with no difference in the hazard ratio for limb events, long-term cardiovascular events. And clopidogrel use was associated with increased bleeding. So you can use it, but at least in this study, post-revascularization, DAPT short-term didn't show to be different. Now, there are obviously going to be lesion subsets, patients with critical limb ischemia, or if you've done DCB, that you might feel comfortable using it. But I think long-term, your therapy is likely to going to be what I'll call dual pathway with at least an antithrombotic. And why that my thinking's changed is I've been interested in seeing not just across vascular beds, but now we see this dose showing cardiovascular benefits too. So I do think it's something, and most notably in Voyager, as you saw, I mean, limb events go down, repeat revascularization goes down. So the durability of your intervention may get improved.
That's Sahil, it's interesting. Thanks, Manish. And, it's really evolving how we consider antithrombotic therapy for after endovascular therapy. I guess, Sahil, I have had a lot of challenges with prescribing this drug because of insurance and reimbursement. Have you had these issues, and what are we supposed to do with this? We have approval, we have the trial, we can't find people to pay for it.
Well, I mean, I think it depends on the payer mix. Certainly, I think that as we know, in the claudican population, we tend to have more commercially insured patients, and in that subgroup, we've had less difficulty. We do need to do prior authorization, but once we get the heavy lifting done, that seems to be less of a challenge. In the CLI population, there's some challenges often in some of the managed plans that we have here in New York, especially for Medicaid. And Medicare, we need to do some paperwork, but we haven't had as much trouble as we thought. But actually, one of our challenges is really the compliance. We know that the more meds we add and the more frequency we add, compliance can be challenged. DAPT is something we're so used to doing, and it's daily, once daily therapy. I've had challenges with people recognizing that their low dose rivaroxaban is a BID treatment. And we've had to really reiterate that. Same thing I think holds true with ticagrelor to a lesser degree in our coronary patients, but the BID dosing is a challenge. We have also had the difficulty with the triple therapy concept. We really do not use triple therapy in our coronary world. Even for coronary PCI, we've moved away from triple therapy. And if we have patients with need for anticoagulation, such as AFib, we do a DOAC and Plavix in those patients. And that was not studied, obviously, in the trial, but it seems reasonable that you could use clopidogrel and a DOAC. It's just not been studied. So I think the Voyager data are a great entree and a proof of concept. And I hope that we'll get an indication and a guideline update. Those things are still pending. But if we get those things, that might help with the reimbursement piece as well.
That's great. I just want to reiterate one thing is that I would highly recommend against triple therapy, as you alluded to. We have multiple trials now in the coronary field that have shown that there is not much benefit except bleeding. So I would not consider triple therapy for majority, if not all these patients. I like your idea. Tomas, please, you wanted to comment.
Yeah, well, we are not talking about the classic triple therapy here. It's a modified triple therapy. The dose of the NOAC is much lower as compared to the traditional dose. It's only 5 milligram in total. And I do have a follow-up question for Manesh. Even if the risk ratio is not different between Clopidogrel users and non-Clopidogrel users, the absolute numbers with the mild triple therapy, they are lower. What's your comment on that?
Yeah, it's a good observation. And the reason I think you're observing that is people who got clopidogrel were probably endovascular patients. And so the endovascular patients, believe it or not, who have coronary disease, were having higher other event rates. So the entire group has a higher event rate, including the aspirin arm, compared to, let's say, the non-clopidogrel group. Again, it wasn't randomized. So when you just look at those curves, you'll say, hey, there's not a difference in hazard ratio, but the overall numbers look lower. Is that a reason I should use clopidogrel? And I would caution that, because I think those are two separate groups, even though sometimes they're presented on a slide. And I guess I would say you're right that total dose of rivaroxaban is 5 milligrams. We know from the large coronary experience with Atlas and Atlas 2 that where we use triple therapy with the 5 or a total dose or with, again, dual antiplatelet therapy, that if extended over time, there's always a bleeding risk. And the question is the efficacy risk. And I don't suggest that you shouldn't use it. I think we have to just learn better about which patients to be thinking about it. Finally, I'll just say chronically, once you're beyond, let's say, 6 months, I think in that perspective there, those patients really do benefit from Compass and Voyager potentially, because most patients aren't on clopidogrel. And if you can get them on it, it would make a difference.
Yeah, Lawrence, I'm going to come to you, and I just want to reiterate that the Plavix cohort was also not powered, so the bleeding and the safety issues need to be taken with consideration, meaning that yes, additional antithrombotic therapy may be efficacious, but also has to be in the context of the bleeding risk. And these patients, because of their comorbidities, are at higher risk of bleeding. Lawrence, you can comment on this, but I also have a question for you I want to ask you. So let me ask you the question, and then you can combine the two. We talked a lot about the clinical trials. We need clinical trials for atherectomy. We need clinical trials for shockwave. We need clinical trials for these calcified lesions. But let's be honest, these are adjunctive therapies. We are talking about the kind of patients that Chris Mesker was showing us. How can a clinical trial, with all the noise that is around, be able to detect the efficacy of these devices? Is it realistic to accept, to believe that the adjunctive therapy, like atherectomy, in complex lesions like the one that Chris is showing us, is going to show an efficacy in a randomized clinical trial? Are we setting the bar too high? That's what I'm asking.
We've had this discussion. I can't remember how many conferences. It comes every time. And I think we're all, with an IQ in the triple digits, we all realize that the benefit of a randomized clinical trial is absolutely the best. But there comes a time where we have to look at even registry data as an opportunity for kind of giving us a signal to a specific question that we need to answer. And I don't think they're mutually exclusive. I think they actually work in concert. And so to answer your question, I think that, no, I don't believe that we need randomized clinical trials for some of these questions. But at the same time, we have to have at least some of the data that would be relatively profound when it comes to registries. And you can do registries pretty well, but to really go, full bore on a randomized clinical trial to answer a very specific small question on some of these things, nobody has the money, nor do we have the gumption to do it. And on the side, I just wanted to ask Manesh, there's a kind of a two-part question. Maybe it's a little loaded. Based on Ascend and everything else that's gone before it, and with Compass, is aspirin dead? And then secondly, are we going to go down the road of Compass or anything else that suggests for our vascular patients, charisma notwithstanding, out to 16 months, but are we going to go chronic kind of rivaroxaban and Plavix or some P2Y12?
Yeah, I'm just going to go quick because I know we're out of time. So Compass not only was stopped early, remember, I just want to remind us, it was stopped early in a broad vascular population. They had coronary and peripheral disease for what was a mortality and mixed difference. So I think likely that's going to be something eventually. If it was the price of clopidogrel, we wouldn't have this argument. I'll just say that. And then early on, the therapy is going to just be changing depending on how we adopt what we think those data are and more coming. Thank you all, by the way.
Thank you. Thank you so much. I wanted to thank all of our panelists and my co-moderators, Sahil and Subhash. It was a fantastic session. I wish we had another 3 hours because the brain power in this panel is unbelievable. So thank you so much to our observers and folks that are watching this.